Hi friends, today I'd like to show you a case which I call the Double Jeopardy because it's a pretty hard cataract combined with a small pupil. I think around 4 to 4.5 millimeter size pupil. After creating a nice rectangular incision, I proceed with the surgery. The first step is the challenge of capsulorhexis. The capsulorhexis in a small pupil should be as large as possible, and we need to try to stick to the edge of the pupillary margin. Although it's possible to perform the rhexis underneath the iris surface, I generally would not like to recommend that, and I think a 4.5 millimeter size capsulorhexis is adequate. Hydrodissection should be done very cautiously. You can't see the fluid wave, so you need to count on the rising up of the central part of the nucleus. My procedure of choice for nucleus disassembly is by a direct phaco-chop technique, and I use a Mohan Rajan sharp tip chopper, which is 1.75 millimeters, and I use a burst mode phaco. So after burying deep within the nucleus, I use the sharp tip chopper to initiate the crack, and then slightly flex my hand so that the chopper goes deep within the substance of the nucleus, and I separate this crack, and I get the separation to extend right up to the posterior base plate, as you can see. I'm sorry about the air bubbles obscuring the vision just a little bit, but I think in spite of that, it's pretty clear how you can stay within the pupillary zone, at least in a direct chop, bury the phaco tip inside the nucleus substance and create multiple fragments using the technique of what I call the paddle chop maneuver. Now once you've broken it down into sufficiently small pieces, I exchange the 1.75 millimeter chopper with a 1.25 millimeter chopper, or sometimes even a Sinskey hook, and I go ahead with fragment removal in the micropulse mode. To prevent the iris from getting sucked into the phaco probe, I'm using a rather low aspiration flow rate of only around 28 cc per minute, and also a low vacuum of 280 millimeters of mercury, which is the reason why you see that the pieces are, the followability and the responsiveness of the machine is a little tardy. The nucleus did not turn out to be as hard as I thought. Because of the black brown color, I thought it would be a grade 4 nucleus sclerosis, but it just shade over grade 2 nucleus sclerosis. And I was able to remove all these fragments whilst remaining within the central pupillary area. You can notice that at no point of time did I fish blindly behind the iris. Neither my phaco probe nor the second instrument blindly went underneath the iris, which means that at all point of time I was in the safe zone, and I was letting things happen in a predictable fashion, and I was allowing the fluidics and the dynamics of the phaco machine to drive the pieces onto the tip. So at the end of the surgery, the wound shows just mild hydration, and there's no evidence of wound burn. When filling viscoelastic for IOL implantation, put the visco in the anterior chamber alone, because if you insufflate the posterior chamber, there is a risk of iris prolapse. I think because my cortical cleavage hydrodissection was rather very effective, there were almost no cortex. In fact, I put in a Coughlin's hook and examined underneath the iris, and there were no cortex, so I decided to go ahead with the implantation of the IOL. I am implanting a hydrophobic acrylic preloaded lens, and I like to implant it straight within the capsular bag. With gentle nudge of the second instrument, I'm able to get the IOL into the capsular bag. So after washing out the viscoelastic from the anterior chamber, I tilt the IOL optic, go behind the IOL to remove the viscoelastic from the posterior chamber and the bag in a segmental fashion. I also attempt to do a pivot rotation because this will help to confirm that the IOL is in the bag, even though I'm not able to see the IOL completely within the bag. At the end of the procedure, I pull out my IA cannula and I seal the lip with a cotton bud for a count of about 10 to 20 seconds. This is usually enough to seal the incision most of the times. Be sure that this particular case I will get a good seal because the wound construction is good. At the end of the procedure, you can see that I have a watertight main port and side port incisions, and the case is successfully over.